सारी चीजें आपके जानकारी से संभव है। आप जानेंगे, जो कृष्ण ने गीता में भी कहा है कि जीवन को शुद्ध बनाने का मार्ग है, धर्म का है, भक्ति का है। ज्ञान हम के हमारे लिए बसता है ज्ञान मार्ग। हम अगर किसी चीज के बारे में बहुत ज्ञान प्राप्त कर लेते तो ज्ञान मार्ग में आती है। मैं अभी डॉक्टर साहब से चैम्बर में बात कर रहा था, तो मैंने कहा कि भाई ये तो मेरे लिए इसी तरह है बॉडी का ज्ञान नॉन मेडिकल होते हुए कि हम साइकिल चला रहे हो और चैन चढ़ा रहे हैं, चैन चढ़ाना जानकारी होनी चाहिए। सर्विसियल नॉलेज होना चाहिए। आज का मैंने प्लान किया मैं करता हूँ और आप सबों की तरफ से पूरे महाविद्यालय के परिवार की तरफ से मैं इनका तहे
without a director are super specialty hospital and resource center private clinic, super specialty hospital and resource center private clinic. He has completed his MBBS in 1992. He has shown that kindness is alive by the occasion of World Kidney Day and has a perfect moment.
That this lecture is really related to the essence of the CKD, and I make the appeal by this month for our future to come forward with the organ donation, either the live, digital, or the kidney failure is of two types. One is the acute renal and another is the chronic renal failure. What is acute renal failure and chronic renal failure? That is very important because the acute renal failure patients will be reversible. That can be reversed back. This will become the normal. But the chronic kidney disease patients, where the chronic kidney disease will not be reversed at all, means the reversibility is not possible. But means that patient requires the kidney transplantation having the CKD. So the prevalence of CKD requiring renal transplant is 151 to 234 for 1 million of the population. So it is a huge number of the patients which require in which you have the surprise that the only the 7,500 that I am going to discuss today in 1 hour. So you have to sit here for the 1 hour to understand the topic actually, that is the obstructive neuropathy. Actually, why I have chosen this topic, the obstructive neuropathy, because 10% of the patients of the obstructive neuropathy will line up into the acute renal failure, that is also known as the AKI, acute kidney injury. And among those, the 4% of the patients will line up into the CKD, which needs the renal transplantation. So this is a huge number. And the most important thing that the most of the patients, among 95 to 98% of these patients, can be prevented and can be treated by functional or anatomic obstruction of the urinary flow at any level of the urinary tract. Any level of the urinary tract, that is from the calyces of the kidney up to the external urethral meatus, that is in the urethra itself. So anywhere in the urinary tract there to have obstruction in the kidney due to the calculi, tumors, even pregnancy can produce the obstruction, tumors, necrosis. So it may be from the kidney up to the urinary orifices. So you see the structure in the microbiome, the anatomy. So you will go ahead from the kidney. That has approximately unilateral or bilateral, acute or chronic, that is time-based, baseline of the condition of the kidney, potential for recovery, presence or absence of the UTI, these all are the impact of obstruction that will produce the obstructive neuropathy and nephropathy. So, after the presentation, this type of patients, how they present that? Actually, they have the urinary features if there is a lower tract obstruction. If the obstruction is at the level of urethra and bladder, that is the distal obstruction, that is obstruction in the lower tract, the features will be, the clinical presentations will be, hesitancy in starting urination, force will be decreased, weak strain, tunnel drifting, burning of the burning on urination, of the urine, and you will land up with like acute urinary infection. Having the hematuria, if the hematuria is gross, frank, paleness, that is coming from the blood, is coming from the upper tract. That's his kidney, from the kidney. So gross hematuria, having the upper tract, ureterus obstruction at the level of ureter. So the obstruction at the level of ureter and kidney, obstruction at the level of bladder and urethra, if the obstruction is in the upper tract, then most of the time the clinical features will be the system. Then patients will present with a fever with chills, nausea, vomiting, cloudy urine with infection, and if there will be bilateral cases, the patients will be having the uremia and so how you diagnose this type of patient? So suppose you have the problem of the obstruction in the urinary tract. So how will you reach on the diagnosis? How will you know that what is the problem is going on inside? So the preliminary investigation, that is initial investigation, is the ultrasound. Ultrasound is the initial investigation that will say you a lot of things. That is the anatomic study. Of course, this is not a functional study, but nowadays the recent version of ultrasound, that is the modified version, having the Doppler modification, may add the functional component. It will give the size of the renal parenchyma, thickness of the bladder wall, ureteral wall. So, however, that is the initial investigation, but it has potential to diagnose the CKD patient. That is, it can diagnose the chronic renal failure of patient. How it diagnoses the chronic renal failure of patient? Because it gives the size of the kidney, echogenicity, corticomedullary differentiations, and refractive index that depends on the flow of the blood in the renal patients. So, if the refractive index is more than 0.7, that is the patient having the obstructive neuropathy. So that the chronic kidney disease, by that and refractive index, that we can diagnose the chronic kidney disease, that is renal failure patient, by the ultrasound. So we can the higher versions having the ultrasound, having the higher version that can diagnose the crossing vessels and ureteric pelvic junction obstruction. Now this type of picture is contained in the ultrasound, and if you want to be the radiologist, then you have to know that this is the picture, normal picture. Ultrasound is how you diagnose the patients having the obstruction and obstructive neuropathy. ECU can get the obstruction and there is the you can handle. Next investigation is the IVU. IVU, that is supposed to be the gold standard. And delayed program and pyelogram, that's also say you the anatomic level of obstruction. And chronicity of the obstruction, that is the parenchymal thinning, calicial blunting, ureteral tortuosity, that can be diagnosed by the IVU. See, to the right side of the kidney. Here, that you can get that right side. You are not seeing the ureter. at that obstruction. So in that case also the physical system and ureter is dilated. But here the ureter is not seen. So there is a clear there is the obstruction at the level. So is only in this area, anywhere in the ureter, we can remove that. We can have an extra laser lithography, percutaneous ultrasonic lithography, percutaneous electrophotometry, that is these all are videos for the removal of the stone. If there is a picture, we can do electrostomy, we can mark, we can remove around. So, many treat the patient and we can get the result and we can normalize the patient. So that is very important. Now, what are the issues? You see the main. What do you do there in that particular case? And you have
सीजन हो गया कितनी तल्लीनता से फोटो खींच रहे हैं फोटोग्राफर कितनी तल्लीनता से फोटो खींच रहे हैं नोट किए और हम भी कुछ है तुम्हारी बहुत क्या हम भी कुछ
you have to do some sort of divert. So what you do to divert in that particular to do that SPC, suprapubic catheterization, to do that, to deal that type of patient. This is the another patient. Having you see that in this particular patient having anterior urethral diverticulum, this anterior urethral diverticulum you see, this is the diverticulum rising starting from the urethra. Here there is a movement, and I put the contrast from here. I have and you see the contrast in a stage. So that is the anterior urethral diverticulum. You can get such type of patient. So what you do that in particular case? This is another patient having prepucial diverticulum, that ballooning of the prepuce, the male patient. That happens like that, and contrast is getting accumulated here. So these all are the patients having urinary obstruction. How you deal urinary maintenance. So that type of patient डिजाइन करेगा ना, इसको AKI होगा ना, इसको क्रोनिक किडनी डिजीज होगा ना, और तब जो है पेशेंट्स को प्रॉब्लम होगा. So you must aware of these all the things. See the bladder, I have done the cystoscopy. See the bladder, and this mass arising from the bladder, this mass, huge mass, and it's protruding inside the bladder. Inside the bladder. बाहर से कुछ नहीं दिखेगा. पेशेंट को पेशाब रोका हुआ है. बाहर से कुछ नहीं दिखेगा. ये बाहर So that is the problem. So these are curative problem. You can cure this. ये नहीं समझो कि इससे बीमारी हो गया तो ये फिर प्रॉब्लम हो गया, नहीं ठीक होगा. नहीं. These type of patients will cure. That I have done the surgery in those patients, and the patient is doing nice, and patient फिर से नहीं आया दोबारा मेरे पास. इसका माने क्या है कि वो सही हो गया, वो फिर नहीं आएगा. तो this type of patients जो है आपको ये देखो another patients है, लेकिन posterior cyst with bladder outlet of the यहाँ पर cyst है. There is a incident in the human, and this is the bladder type, and this is the huge at the neck of the bladder. So that can be dealt by simple, when you see मेजर और पेशेंट जो है सही हो। So this is the posterior urethral slit. This is another patient with calcium at bladder neck mass with the bladder neck bladder outflow obstruction. So this type of calcium pad you can do the radical cystectomy and radical urethrectomy, and you can make the patient cases. So that type of patient is there. This is the stricture urethra. That's very common, especially in the age in that urethral stricture is very common. This is a iatrogenic urethral bleeding. Iatrogenic means that is caused by the doctor itself. वो some आदमी जो है गांव में या विलेज में या जहाँ पर फैसिलिटी अवेलेबल नहीं है वहाँ पर इसको डायलेटर डाल करके पेशाब के रास्ते में डायलेटर डाल करके इसको स्ट्रक्चर फॉल्स पैसेज बना दिया और फॉल्स पैसेज बना दिया उसको हाइड्रोजेनिक यूरेथ्रल इंजरी हो गया, मैसिव यूरेथ्रल ब्लीड हुआ, उसके बाद उसको यूरेथ्रल स्ट्रक्चर हो गया। उसके बाद देखो कैसे यूरेथ्रा जो है दो पार्ट urethra is divided into the two parts here and there is the septum. So this type of patient will be treated and will be cured and will be prevented from the AKI, kidney injury and chronic renal failure. See, this is the false passage कैसे बनाना? Even cases such as hydrogen, false passage बनाना। The false passage honeycomb. Urethra there is no lumen. And that entire urethra is burned like anything like honeycomb structure, cavity हो गया. That patient can be cured by the urologist, by the proper treatment, and by the endoscopic procedure. By the simple endoscopic procedure, you can treat this type of patient. This is another patient. पेट से गिर गया बच्चा और उसको यूरेथ्रोक्यूटेनियस फिस्टुला हो गया. इसमें जो है घुस गया, यहाँ पर पेरिफेरिया में जो है डंडा जो है घुस गया, and that sense urethral stricture बना, urethroperitoneous fistula. That is urine is coming from that is the urethroperitoneous fistula. See, I put the jelly actually in this patient. I put the jelly from the urethra and is coming from. That is the urethroperitoneous fistula. Or that is the MCU picture. See, that area has gone from here to here. That area has gone. Actually, this area has gone. That has been reconstructed. That has been reconstructed by the substitution urethroplasty, and that patient having dermal graft that is tubularized. That is, you see that very important to see this. Dermal graft has put. Dermal graft has put here. Dermal graft has put here and tubularized and reached the urethra, and urethral continuity has been maintained. See, this is the patient. Distal anastomosis is completed, and finally, the RQ after 6 months of the urethroplasty that has been reconstructed. So, urethra has been reconstructed in that particular case. See, this is the completed progressive perineal urethroplasty in 9-year-old child. This is another patient having the posterior urethral, dilated prostatic urethra that has been posterior urethral with PUR. Now see the upper urinary tract. See the UPJ obstruction, retrocapal ureter, congenital vena ureter with or without PUR, renal and ureteric calculi, ureteric masses, necrosed papilla, ureteric stricture. These are all other problems related to the upper urinary tract obstruction. That can be associated and patients can be cured. This is the UPJ obstruction. And the obstruction that is taken. This is the UPJ. Means the kidney and ureter. And जहाँ जोर होता है वहाँ पर obstruction. That can be dealt by. For the non-functional lower body. This is the kidney from here up to here. in which half of the kidney is obstructed, half is good, half is good, half is obstructed. We have removed the half of the kidney with preserved this kidney. So patient having the 1.5 kidney and the patient will be cured in that particular situation. See, that if half of the kidney has been excised, that half of the kidney has been excised. This half of the kidney is there and half has been excised. So this is another patient having 500 ureteric diverticular excised, and this is the picture actually at initial period of my practice that is in between the 2010. Actually, that time I had done the bilateral ureteric diverticular excision and open cross trigonal reimplantation. So ureteric reimplantation. So this is the picture of that. So the picture is not very good. This is another picture in the retrocaval. This is the ureteric. और यहीं पर यहाँ पर वेना के बाहर रखा है राइट साइड में. So this ureter is trapped behind the vena cava at this level. See, usually the vena cava is the medial to the ureter. So in this particular case there is a congenital anomaly and this ureter is trapped inside. This is known as the retrocaval ureter. The ureter is behind the vena cava. So this is the same patient is having that. Now what we have done in that particular case, see, this is the vena cava, this is the vena cava, and this is the ureter, this is the ureter, this is the ureter. So what is done? I just inside this, transected this ureter, and we transpose the ureter, and we have done the intravenous osmosis. So in that particular case, there is transection of ureter, transposition of ureter, and there is the continuity. This is the picture. This is another picture. Having the same patient, having the intravenous osmosis done at this level. So this is the retrocaval ureter that has been treated. So this is another patient. See, this is a unique patient. Having this look like that patient actually consulted by the physician. And physician diagnosed having the ascites, and what he was doing, that he was taking the urine, that is urine actually the ascitic fluid repeatedly and trying to remove the ascitic fluid from his abdomen. But he came to me that I have done the CT scan, and what was the CT finding? Actually, the kidney is hydronephrotic, and that was actually the second case in the world I have drained the 30 liter of the urine from his left kidney. That's it. One bucket is being filled up, another bucket is coming out. See, the bag is also, this bag is also filled up, another bucket is filled up, this bag is filled up, and there is the PCN in the left kidney. So I searched the literature and found that there is this second case. The only one case still now reported having drained the 35 liter of urine. So this is the second case I measured. I published in the Indian Journal of Urology that case, and having the 30 liters of urine drained from their kidney. So this is this type of obstruction you can get, and that patient has to be controlled. How will that control? Actually, this kidney is not functioning. I have done the TT scan after that, and this left kidney was not functioning with the normal right kidney. So what I did the left nephrectomy, and now the patient is cured. And since the 10 years, the patient is not coming to me because the patient is normal. It's not the loss actually. I found out that the patient is absolutely normal with the one kidney. So this is 30 liter zinc hydronephrosis. That is the level. Let's see how that kidney is. This is another patient having zinc retroperitoneal mass producing the hydronephrosis and the renal gland actually. Another patient having this schematic diagram that can show that there is a ureteric obstruction and how you deal that type of ureteric obstruction. And for example, there is the loss of the ureter. there is a loss of urine from here to there. How do we do that? We can tubularize the bladder. We can take the flag of the bladder, we can tubularize the bladder, and we can add this one, we can connect this one, and we can enhance the most from here to there. That is a body that is come from. See, there is the loss of urine. Anyhow, everything urine. Whatever the cause, there is a loss of urine. There will be the sometimes the gynecologist do the surgery and they will in that particular case, you can tubularize the ureter and you can do the body plan. See, this is the ideal ureter, ideal ureter. If the ureter, if that is not sufficient and length is very much too much, that can be very difficult to bridge. We can take the idea, that is industry. Then you can take the industry and you can make a connectivity from the kidney up to the bladder. That is known as the ideal ureter. These all are the substitute